Now coming to lack of alpha oxidation of fatty acid leads to. It's a very popular question, and when we have problem in the alpha oxidation of phytanic acid, which is a branch in fatty acid, we tend to have accumulation of this branch in fatty acid, and this result in a neurometabolic disorder which is called Refsum's disease, where this branch in fatty acid starts accumulating, giving the problem of developmental delay, motor neuropathy, right, and R for retinitis pigmentosa and blindness, childhood blindness. Then there will be dryness on the lower limb. Extraphalanges has also been described in Refsum's disease. So Refsum's disease is a neurometabolic disorder which is due to defect in alpha oxidation, which is very, very important for oxidation of a branch in fatty acid, which is phytanic acid. So if we have defect in alpha oxidation, we have accumulation of phytanic acid, which will result in Refsum's disease. And the enzyme which is defective of this alpha oxidation is which one? It's a phytanic acid alpha oxidase enzyme, or phytanic acid alpha hydroxylase enzyme. So we have this enzyme, it's the same name, synonym, phytanic acid alpha oxidase or hydroxylase enzyme, which is deficient in Refsum's disease. Coming to next question, true about nucleotide excision repair except. So what is wrong regarding nucleotide excision repair? So only the damaged nucleotides are removed is the answer in this question, because it is not only the damaged nucleotide which are removed. When we are talking about nucleotide excision repair, we have double-stranded DNA like this, and this is like say for example thymine dimers, which are produced on exposure of this DNA to ultraviolet light. So this is called thymine dimerization, and a large segment of the DNA strand is getting affected. And during NER, during nucleotide excision repair, we have cleaving of this DNA at two ends on either side of this thymine dimerization, that will remove a large segment of the DNA, that is going to create a gap which is going to be filled by DNA polymerase, then DNA ligase is going to unite it. So it is very clear that it's not only damaged nucleotide which are removed. Right, damaged nucleotide are only damaged nucleotides are removed. It never happens as such per se. If you talk about DNA repair, always some extra normal DNA portion is getting sacrificed. Whether it is mismatch repair, or you talk about nucleotide excision repair, or you talk about base excision repair in that manner. Base excision also is not just removing the single nucleotide. Please understand, some 3 to 5 nucleotide segment is getting removed in the base excision repair also. There's single base which is like modified, but to correct that problem, minimum 3 nucleotides, one on adjacent side of that defective base, or 2 nucleotide adjacent on to this defective base, that will constitute your 5 nucleotide segment is getting removed even in the base excision repair. So we are not so blessed that only defective nucleotide is removed and that is getting getting incorporated. The right nucleotide is getting incorporated at that point. It never happens in the DNA repair process. All other statements about the nucleotide excision repair given in the questions are right statement. Like for example, when you talk about damaged base occurs only on one strand of the DNA, that's right. Most of the time when you talk about nucleotide excision repair, when this thymine dimerization occurs, it occurs on single strand, either strand, upper or lower strand, any one strand is getting affected, and whatever strand is getting affected is undergoing repair. So the other strand is just, it's observing what is happening, and ultimately when gap is created, it will provide you the template for that gap filling process. Right? And I have already told you the thymine dimerization produced by ultraviolet light is removed in the nucleotide excision repair, and it requires ligase and polymerase. So of course, like first the exonuclease, which can excise the DNA segment, then DNA polymerase, and then ligase enzyme will be required to complete the process. And any defect in overall process results in a disease, and that's why frequently asked xeroderma pigmentosa. You remember, xeroderma pigmentosa is the disease which is autosomal recessive disease, and as name implies, xeroderma, dry skin, and hyperpigmentation, blistering on the skin, especially on exposure to sunlight. The baby will be presenting totally disfigured face and weeping blisters. So it's a very pathetic condition, and it's a pre-malignant condition where the baby is very much prone for developing the skin malignancy, and this unfortunate condition is because of defect in nucleotide excision repair. Coming to next question, when we talk about inner mitochondrial membrane, we understand it's very much impermeable. So God has given a lot of transporters which can, facilitate entry of many substances in and out of mitochondrial matrix. So in that context, when we talk, we have transporter for many things. We have transporter for acetyl-CoA. It's not acetyl-CoA. We have transporter for ATP, ADP. We have transporter for NADH, NAD, we can say, and NADPH. See, what is this question asking you? Which transporter it is having? So the answer is going to be ATP, ADP antipode system. ATP, ADP antipode system is present on the inner membrane mitochondria, and that you learn during oxidative phosphorylation, that whatever ATP is produced in oxidative phosphorylation has to come outside, and in exchange the ADP should be supplied in the matrix, which is going to act as a raw material for making of ATP during the process of oxidative phosphorylation. So to facilitate this process, we have an antipode system on the inner membrane mitochondria, which is called ATP ADP antipode system, which brings the ATP out and sends the ADP into the matrix. So we have the antipode system only for this. All other things, like when you're talking about NADH and NADPH, we do not have any transporter. So you'll say, how, madam, that glycolytic NADH is going to the matrix and producing ATP by oxidative phosphorylation? You are mistaken. That NADH which is produced in cytosol during glycolysis as such cannot go to the mitochondrial matrix because it is not having any transporter. It's not permeable. Rather, this NADH is using the shuttle system, that is malate aspartate shuttle or the glycerophosphate shuttle, for transporting its reducing equivalent to the matrix, which is like captured by the coenzyme in the matrix by either FAD or NAD, which immediately are turning their shape and structure, converted into FADH to NADH in the matrix, and they enter the oxidative phosphorylation producing ATP. So in a nutshell, what I mean to say that NADH from the cytosol directly is not able to go to the matrix. Rather, it is just dropping its hydrogen in the cytosol in one of the shuttle system, and that shuttle is carrying that hydrogen to drop that hydrogen into the matrix where coenzymes are ready to capture it to and they are modified into reduced coenzyme form, and they enter the oxidative phosphorylation process. This is how the NADH is like able to produce UATP in the matrix. And when you talk about acetyl-CoA, it's good like God has not given the acetyl-CoA transporter on the inner membrane, otherwise our whole system would have gone haywire. See, the acetyl-CoA is something which is produced in the mitochondrial matrix, whether it is coming from glucose oxidation, or it's coming from fatty acid beta oxidation, or it's coming from amino acid oxidation. Acetyl-CoA is always mitochondrial. And God has told that this acetyl-CoA should go to the TCA cycle. If the TCA is accepting acetyl-CoA, no one else should use it. Now, so the acetyl-CoA need to go to the TCA cycle, and God has not given any transporter for the acetyl-CoA. Otherwise, it will come outside and will spoil the whole biochemistry. So the transporter we do not have. So when the liver is having surplus amount of acetyl-CoA, which is not able to go to the TCA cycle because it's already saturated, then liver thinks like what to do with the surplus acetyl-CoA. That moment the acetyl-CoA is converted to ketone body, and that ketone body is permeable to our mitochondrial membrane. It comes out and circulates in the plasma. So ketone body can come out, but acetyl-CoA cannot come out. Similarly, in well-fed state, when the fatty acid synthesis has to take place and glucose is generating a lot of acetyl-CoA via its pyruvate in the matrix, that acetyl-CoA wants to come to the cytosol because it has to go for fatty acid synthesis, which is a cytosolic process. But God says कि you are not permeable to mitochondrial membrane. So that time acetyl-CoA condenses with oxaloacetate to make you citrate, and that citrate transporter is there on the inner membrane. Via citrate transporter, that citrate comes to the cytosol and gets converted to acetyl-CoA and oxaloacetate once again, and that acetyl-CoA goes for fatty acid synthesis. So you have to understand the basic concept, what is there in biochemistry. Simply mugging up the pathways and enzyme names, and learning bits and fractions of biochemistry will not help you, right? So you should know that acetyl-CoA transporter also be not having. So whenever acetyl-CoA wants to come outside, in well-fed state it comes in the form of citrate, and in starved state, when the fatty acid is producing a lot of acetyl-CoA, it comes out in the form of ketone body. Right. And when we talk about NADPH, see, NADPH को जाना ही नहीं है matrix में. NADPH is something which is produced in the cytosol, and NADPH is something which is utilized in the cytosol itself. Mitochondria says, I don't require you. So there is no transportation of NADPH across the membrane. So NADPH is the supplier of reducing equivalent for synthesis of fatty acid, for synthesis of cholesterol, for synthesis of bile acid, for synthesis of steroid hormones, and all these processes are taking place outside the mitochondrial matrix. So the pathway which is producing NADPH and the pathways which are utilizing NADPH are all cytosolic. So the God has not created any transporter for NADPH because this is not as such required. Mitochondrial matrix will say, मैं क्या करूँ? What all I will do? I will not do the fatty acid synthesis. I will not do the cholesterol synthesis. So I will not require you. So this transporter is not present on the inner membrane mitochondria. So now it's very clear. So you have, I have given you in the explanation sheet that what all transporters are there. The whole list is there. You go through that. Now coming to question number 12. Mitochondria codon are exception to the universality rule, and the initiation codon, which in mammal is AUG, generally by default for genomic DNA, we say AUG is the start codon which codes for methionine in eukaryote and for methionine in prokaryote. In mitochondria, methionine is coded by something else. When you talk about mitochondrial DNA, its mRNA and its whole process of translation, the methionine is not coded by AUG, rather it is coded by AUA. So this you have to remember. This is exception to the rule of genetic code. Now true about vitamin K except. So what is wrong about vitamin K? Vitamin K is not going to shorten the PT, prothrombin time. Rather, vitamin K deficiency, vitamin K is deficiency. Ideally, it should be vitamin K deficiency, right? So vitamin K deficiency, you will have prolonged PT. Because the clotting factors are not acting properly because they are not post-translationally modified in lack of vitamin K. So they will say, I will not do the clotting, and that will result in increased clotting time, increased prothrombin time. So PT is prolonged, not shortened. And all the statements are right regarding vitamin K, that the storage organ is liver. See, fat-soluble vitamin A, D, E, K, they are stored in body, and liver is the major organ which is going to store all this fat-soluble vitamin. So K is stored there, no doubt in that. Cofactor for coagulation factors. Yes, there are coagulation factors 2, 7, 9 and 10 which undergo post-translational modification where the gamma carbon of glutamic acid is undergoing carboxylation, imparting the negativity to these glutamic acid which attracts calcium, and that will help in the clotting process. And deficiency results in hemorrhagic disease of newborn is also right. See, I have uploaded a video on vitamin K, on Facebook Club. So you can go through that video. There are a lot of things, unique things about vitamin K I have discussed. So it's hardly some 15-20 minutes video. I request you to search this video on Facebook, DAMS Exclusive Club, and learn that. Coming to 14th question. Metabolic adaptation of alcoholic is all except. So NAD is not high, it is rather NADH which is high. So this is the answer in this question. But otherwise other things which are given in this question is all right. In alcoholic you have lactic acidosis, you have fatty liver, you have decreased uric acid excretion because of lactic acidosis. See what happens when you talk about ethyl alcohol, which is in layman term is the alcohol, C2H5OH, alcohol, ethanol, that's converted to acetaldehyde, which is then converted to acetic acid. This is by alcohol dehydrogenase and this is by acetaldehyde dehydrogenase, and the beauty is that both these two enzymes need the same coenzyme NAD, so resulting in the formation of NADH. So if a person is consuming alcohol for long duration of time, what happens? There occurs increased NADH in the liver, and this is going to spoil the show. When the liver is having a lot of NADH, the oxidative phosphorylation says, "मैं कितना use करूं?" So what happens? The rate of oxidative phosphorylation is slower compared to that, the oxidation of alcohol. That's a pretty high rate. So liver will have excessive accumulation of NADH, and that's going to spoil the metabolism. This excessive NADH will start converting the pyruvate to lactate, which will result in lactic acidosis. And you must have heard, if a person consumes a lot of alcohol, and if the person is prone for getting the gout, he develops the gouty episode on consumption of alcohol. That can be explained by this metabolic process, where increased NADH is going to convert a lot of pyruvate to lactate. That will result in lactic acidosis, and you should know that lactic acidosis, for whatever reason it is going to impair the uric acid excretion. That will result in hyperuricemia. So this is very well seen in alcoholic patient and explaining the gouty attack in alcoholic patient. And fatty acid accumulation is because of decreased turnover of fatty acid. Because fatty acid oxidation needs NAD, and when a person is taking alcohol, a lot of alcohol, there is NADH, not NAD. So in lack of NAD, what happens? The fatty acid oxidation is not taking place, and deposition of fatty acid is the one which is responsible for fatty streak in the alcoholic patient. So don't simply loosely say that it's increased synthesis of fatty acid in the liver in alcoholic patient. ऐसा नहीं होता. It is not increased synthesis. It is rather decreased fatty acid turnover, decreased fatty acid oxidation, which is responsible for fatty streaks, which in long duration will turn into cirrhosis, and which become irreversible. So answer for this question is, which of the following is true except, so high NAD level is not the answer, is not the, statement correct for alcoholic patients. So that is the answer in this question, right? Now coming to question number 15, which human tissue is having greatest amount of glycogen? And the answer is going to be skeletal muscle. See, when we talk about percentage wise accumulation of glycogen in the liver, in the skeletal muscle, we have 4% of glycogen is stored in liver and only 0.7% of glycogen is stored in skeletal muscle. But because we have more of the skeletal mass, the total amount of glycogen which is there in skeletal muscle in toto is 245 grams, and in liver, depending on its weight, if we talk about total accumulation of glycogen in the liver, we have just 72 grams of glycogen. So in this question is being asked that human tissue containing greatest amount of glycogen. So obviously it's going to be skeletal muscle. Cason's disease, always called endemic cardiomyopathy. Endemic cardiomyopathy is due to selenium deficiency. If the soil is having deficiency of selenium, which is commonly seen in certain islands in the China, the whole of the population residing in that locality is found to have deficiency of selenium, and this deficiency of selenium in the soil is not a small thing. It's going to have its impact on the heart, and the heart failure, the cardiomyopathy will be seen in the residents residing in that locality, and that's called endemic cardiomyopathy or Cason's disease. So that you should know it's because of selenium deficiency. Selenium is actually 2/8 salt. If it is less, it's going to result in Cushing's disease. If the selenium in the soil is high, it will result in selenosis, which is characterized by unique kind of dermatitis, peeling of skin, and redness, erythema, kind of, and irritation on the skin. So that's selenosis. That's because of excessive selenium in the soil.